What happens after an elbow dislocation? Don't worry, Connor McDavid did not have an elbow dislocation. He's just up there for eye candy because he is a super athlete and Edmonton Oilers, and they're going to win the cup, hopefully, with the new goaltender. And Shesterkin's out. Yes. Okay, so for a lower body injury, but we're not talking about that because we don't know what it is. They don't really see information. So elbow dislocation. I'm Doc Feisel, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. So you have an elbow dislocation and you go back to play within a few weeks. Pretty impressive, eh? Would you or I do that? Maybe if we have a desk job. But if you're an athlete that has to use your arm for all sorts of activities, catching, throwing, blocking, landing, crashing, falling, would you go back with a recent elbow dislocation? Probably. Really? Well, let's look at that. So if you just have an isolated elbow dislocation and say it's a very straightforward, you didn't blow out the LUCL, which is the big, important ligament that everyone gets their elbow reconstructed. So say you did. So now it's solid. You have some rope, you have some graft, you've got it repaired, it's solid, it's healed, you're moving it, you got your motion back, you got your stability back. Are you gonna go back and play in 4 weeks, 6 weeks? That's a question for the athlete, the sports team doc, and the trainer and the coaches and all of that. Now, obviously the ultimate is the medical decision making, but it's also the athlete choice, right? It's a sort of a gray area. Like, what if you're at risk for injury, but the athlete decides to play anyways? Is there liability? Who has liability? What does the insurance do? What does the team do? Who takes responsibility for all that? In the end, it's the athlete's choice, but they are employed by the team. And if they're out, do they get coverage for insurance if they played without medical leave? And if they're on medical leave, how does the team doctor decide that they're going to play? So those are good questions. So elbow dislocation, when you pop the elbow out, simplistically, an elbow is not a simple joint, okay? Simplistically, let's think about it as a hinge, okay? So this is part of an elbow, all right? What inserts in here, this is your forearm bone, the ulna, and this is your olecranon. This is what don't hit people. But you have a ball and hinge joint that goes here, and if this pops out, then you've got your joint capsule and maybe some tendons, maybe some ligaments, and maybe a neurovascular injury, nerve vessels. But let's say you have an elbow dislocation, posterolateral dislocation is common, and you don't tear all the major ligaments, you tear the joint capsule, you don't have a fracture, or you tear the most common ligament, which is reconstructible and repairable, and we have all the data and all the surgeons that know how to do the doc repair, and then you can kind of come back. So if you're stable and your pain is managed, could you come back sooner and play and put your elbow at risk? Sure, why not? How soon is that? It's variable. You got to rehab it, you get your strength. The limitation, of course, is how do you know you're ready? Do you have the confidence to play? Are you going to push hard? It's the playoffs. You're going to push hard. So if you're going to push hard, how far is hard enough? We don't really have that real world kinematic objective data to say, okay, your health score and elbow stability, elbow strength, elbow mobility, elbow agility, and function and endurance and recovery and readiness to play is X. So if we don't have that score that says it's 90 or 95, and then do we have a bar of what's ready to play? What's your readiness to play? We don't have that right now. So what does that mean? So that means that it really comes down to more subjective variables that, well, it typically takes the biology 6 weeks to heal. Then you need 6 weeks of rehabilitation. Now, a lot of that are frameworks of understanding of, from scientific principles to clinical applications to general clinical workflows in majority of patients over time and experience. But I know for a fact that athletes heal faster than that. I had an ACL tear in a 16-year-old who, against my medical advice, went back to doing somersaults and jumps in the air and landing on her feet within 3 months after I did her ACL reconstruction. I was blown away by it. And even the mom says, yeah, I know, I was amazed. I can't believe she did it. And even the athlete said, yeah, I felt great. I went ahead and did it. And I was like, okay, you realize you're at risk for injury. She goes, I know, but I really wanted to play. So in firsthand experience, I have seen athletes just push themselves. So athletes do know their bodies. They do know and have a sense of stability and function, because like there's always this disconnect, I feel sometimes. And that's why it's important for, as a physician, to listen to your patient. All you can do is explain what you know, explain the biological principles of healing, explain the rehabilitation, and then you have to sort of go by, there are some medical legal frameworks or clinical guidelines, and you have to try and stay within those bounds, because you don't want to put yourself or the patient at risk for injury that poses a risk to themselves, or for you, for that matter, for giving the wrong advice, right? And it always comes down to the patient. So if you have that honest, direct conversation with the patient saying, if you go back in less than, let's just say 12 weeks is the magic number for an elbow dislocation for them to go back from a clinical guidelines standpoint. And you say, you can go back at 12 weeks if you've achieved 80% of your rehabilitation goals, and whatever. I'm not saying don't take that as, written in stone, because it's not, right? You'll see all sorts of different, frameworks and workflows. But as long as you explain that to the patient and say, well, I'm going to play. I'm like, okay. In some cases, like high school, college, you need a release from your doctor before they'll let you play. In the pro sports, what kind of a release do they need? That's a separate gray area. Maybe we'll get one of our sports consultants on and do a session with him. That's actually another one we can do in the off season. So anyway, so there's this whole gray area about athletes returning, but in the end, an athlete is going to return. Like, for example, Mark Stone, Vegas Golden Knights. I was so unhappy with him playing when the Oilers lost, because he played through a chest wall, rib fractures, sternal injury, all sorts of injuries, and he pushed through it into the playoffs. And I can tell you that I'm sure he got the advice, don't play, you're going to put yourself at risk. And eventually he had to stop. But I mean, it just goes to show how powerful and passionate and incredible an athlete Mark Stone is. I mean, I'll give him credit for that. I mean, I didn't like how he played against the Oilers, but he was an incredible athlete. And so, kudos to him for that. So it really goes to show what they can do. Now, with an elbow dislocation, because I know your next question is, well, what else can you do? I know there's anti-inflammatories, therapies, modalities, complementary, alternative. You can, as long as you don't have nerve, vessel injury, muscle strength, all of that's coming back. How do you protect the elbow? Well, you can't play in a cast for the elbow, right? I mean, you're going to hurt yourself or hurt someone, right? It's different from a thumb spica cast that's, some players can use, different from a knee brace, which like a lot of defensive linebackers will have to use or play with if they've had injuries in the past, and they can. And for example, NCAA Division I, if they have, a certain tear, they have to go back with a certain type of a knee brace. There are elbow braces out there. There are soft, pliable ones, and then there's more rigid elbow braces. And if you pad it up and you protect it, and do you limit the range of motion? Like, that's the other thing, is how much range of motion is okay for an elbow dislocation? Well, if that elbow is unstable at the 30-degree mark, 60-degree mark, 90-degree mark, at what point of stability is it safe? And then do you lock the brace at that stability point? That's really a tough question. Now, these are super athletes, so their neuromuscular components and functional muscle units are so powerful. Then could they manage that stability? Can they relearn? It's not like they're rewiring, but let's think of it that way, that they're recoding their neuromuscular junctions and neuromuscular brain connectivity to say, okay, I'm going to provide the stability and do this. But will it happen in an instant? Do they have that reactionary speed? Well, of course. They're athletes, right? They're super athletes. They're pro athletes. They've been doing this for years. Since they were 4 years old, they've been playing. They've learned to adapt. So the speed at which they're firing is super fast, right? So can they play without a brace after a recent elbow dislocation? My feeling is I would not be comfortable with having an athlete go back without an elbow brace if the elbow brace is allowed, in less than 6 weeks after an elbow dislocation. But I could have a very different opinion from 100 surgeons out there, or 10 surgeons, or 5 surgeons out there. That's okay. That's why we have different opinions. Everyone has a different safety risk level. Everyone has different experience. Like if you're talking to the team doc who's basically been treating pro athletes at the NFL level for 2-3 decades, they will have a completely different understanding of the super athlete than another doc who treats recreational athletes, right? Huge difference. And then it's also the relationship they have with the player. Do they, in terms of their trust? And, it also comes down to, what does the examination feel like? You have to go back to what that feels like. So, in any exam, can the athlete keep their elbow stable? How much range of motion? Do they wince? Do they react to certain motion? There's a special maneuver we do for elbow dislocations, kind of like a reverse pivot shift, where it's kind of like you convert the elbow into a knee, and you do a pivot shift type to look at their LUCL. That's one of the major ligaments in the elbow, and you look at that to see what the stability is. And so there's also the manual component of the exam. Now, if we had the wearable high resolution precision joint kinematic, which is part of the Kinesi system and platform, a whole different ball game where you're actually getting objective metrics of the knee. We don't have that for the elbow yet. But the point of the matter is that if you don't have those real world kinematics that are providing objective real world data telemetry, just like a Formula One car is giving you in performance athletics, then you're kind of limited by what you do in the exam. You kind of like check the stability, you look at this, you look at their strength, you look at the physical therapy reports, your therapist is down the hall, so you go there, see how he's doing with strength training, throwing, blocking, all sorts of things at various stages. But there are limits. I mean, I've been amazed, like for just everyday people, dislocate their elbow and they say, you know what, my motion's back. It's like, 3 weeks, 4 weeks, because sometimes you can get away with it. You're not pushing yourself that far, but these athletes are pushing themselves that far. So are you taping it, kinetic tape, wrapping it, bracing it, stabilizing it, padding it? Do whatever you need on top of all the other treatments, injectables, regenerative, medications, anti-inflammatories, cold, hot, heat, acupuncture, rolfing, cupping, you name it, they're doing it. Sprays, analgesics.